Before discussing and coming on to the CMEs, I would like to again remind you of regarding the workshop we are intending to have on 30th of September on stroke patient management for clinicians, jointly organized by the SLMA and KSM. Actually, this is a WHO sponsored program. We thought of having 40 participants physically in this auditorium, and the lecturers will be coming online, and there will be a workshop as well, so which will run through the whole day. So I think it's a very important one, which they will give a handbook as well as a good certificate, which is accredited by the WHO. So therefore, I hope that you will be interested on that. Secondly, on 6th of October, we'll be having the foundation sessions at Oak Ray. According to the country's situation, we are not 100% sure which kind of arrangement will be there, but we hope to have a hybrid conference at least. So we will give you all the details in the coming days. Coming back to the CME program, today I have a very dear colleague of mine to talk on blocked nose, our ENT surgeon from National Hospital Kandy, Dr. W.M.C Narampanawa, who obtained his MBBS in 91 actually, and then obtained his otolaryngology and head and neck post-graduation from PJM Colombo in 1999, and obtained his board certification in 2001, and proceeded for his foreign training and got his training in Newcastle, UK. He's has a special interest in head and neck surgery, and he is in the College of Otolaryngologists of Sri Lanka for more than 15 years in the executive committee, and he is an active member of the KSM, holding the vice president's post at the moment. So he has served all over the country, more than 6-7 main hospitals covering Sri Lanka, and he's a keen photographer and also engaged in a lot of other activities like hiking. So it's good to associate in all those activities. So without taking much time, so I would like to invite Dr. Narampanawa to proceed with his lecture on blocked nose. And today's lecture is sponsored by Dr. Reddy Pharmacies.
Good morning, everybody. Thank you, Manjula, for your kind introduction. Manjula and I were together for, I think, more than nearly 40 years now. We were in the actually same batch in the university. Those days, dental, medical, and veterinary science, all first years were similar, in same faculty. Lectures are together. So, Manjula is the one who got me to do this presentation. So I thought of doing something simple and common problem as well. So it is the blocked nose. So why do you have a nose? So can be a lie detector according to some cartoons, and it can hold the spectacles, or ladies may be wearing ornaments. But on top of that, it gives you your personal identity, the appearance. I think you all know this lady is one of the famous Bollywood star, Madhuri Dixit. One of the Indian rhinoplasty surgeons says she has the aesthetically perfect nose, Madhuri Dixit. So, what does it actually do, the nose? It is the primary organ of smell, and at the same time, it plays a major role in respiratory system. and also involved in tasting and speaking, speech resonance and articulation. So before going into details of those things, better have a small idea about the anatomy and the physiology of the nose. Nose is a passage which is divided into two by the nasal septum in the middle. It's usually in the middle, maybe on a side. And the lateral wall is not a simple straightforward wall. It has several projections and grooves like thing. They are called turbinates, and the mucosa is pseudo-stratified columnar ciliated with mucus secreting epithelium. So these are turbinates, and under this all the meatai. And there is a kind of functional valve in the nose, which is supposed to be the narrowest place. It's somewhere here, somewhere here. So we'll come to that later. And it is not alone. You have sinuses, 4 pair of sinuses all around the nose. So that is with the basic anatomy. And this thing, this roughness on the lateral wall make the airflow through the nose turbulent. So it is not just a easy airflow, it is always turbulent. It goes all around. So that helps the function of the nose. I'll come back to that later. So a bit about smell. To go back to this, the olfactory epithelium is situated somewhere here in the roof. So because of the turbulence airflow, when we breathe in, the air flows towards the roof and that stimulate the sensory nerve ending for smell. And smell plays a major role in tasting also, because when we eat, when we bite, it releases certain chemicals that get evaporated, then it travels through the nose into the respiratory epithelium to the roof of the nose, and you feel the smell also. So to get the proper taste of most of the food, you need the smell also. So if you lose the smell, to a certain level you lose your taste also. And then the respiratory function. It is actually the air conditioner of the body. So again, to go back to the anatomy, the ciliated epithelium terminates and the mucus secreted in the nose plays the major role. Cilia is there, they always move backward, and there's always a flow of layer of mucus which travels from the nose into the oropharynx and we swallow it. So that mucus catches the harmful particles and dust and everything, and it moves into the oropharynx. And at the same time, this mucus, it manages the temperature. It warms the air we breathe in to the desired level, and also the moisture. Humidify the air to the desired level so that it's easy for the lung to work with. At the same time, during exhalation, the excessive moisture in the air is reabsorbed. So it plays some role in protection of covering the water balance, and also the temperature is reabsorbed. As I said earlier, the concha or the turbinates and the irregularity in the nasal passage make the airway turbulent, which make the function easy. And on the speech, normal speech resonance, your personal speech is the balance between nasal and oral sound energy. If more energy passes through the nose, it becomes hypernasal. If it is low, it becomes hyponasal. That means That is the voice you get when your nose is blocked. And if your nose is blocked, there is some problem in articulation also. You can try, keep your nose closed when you have a time, and try to say some word in Sinhalese, like try to say amma or king, then you can't pronounce the correct word if your nose is closed. And God or somebody who created us done a marvelous thing. He has joined the nose and the mouth all together before going into the larynx. So why can't we breathe through the mouth without breathing through the nose? There are various reasons. One is one of the pulmonologists in Cleveland is still working. He said, we humans are designed to breathe through the nose from birth. We are obligatory nasal breathers according to him, but there are a lot of exceptions. That's the way humans have evolved. In a way, that is true because it's the job of the nose to condition the air we breathe. Other than air conditioning, it has various other advantages. One is the production of nitric oxide. When you breathe through the nose, in the nasal and the sinus mucosa, we get some production of nitric oxide. Go and see what's the effect of nitric oxide. And the mouth breathing does not. And on the other hand, if you breathe through the mouth, there's no air conditioning. You breathe dirty air and it makes the oral cavity and the mouth dry, which predisposes the throat and the other organs in the oral cavity for infection, and it can reduce the sense of taste as well. As I said earlier, the obligatory nasal breathing. And we are actually now at our age, we are not obligatory nasal breathers. But as soon as the baby is born, they are obligatory nasal breathers. That can last up to 2 to 6 months, some says, and some says up to 1 year. And there are also some exceptions. Not all the babies born are obligatory nasal breathers. There can be exceptions. But it is a big problem, so you have to identify them very early, just after the birth. Otherwise, they die. And that obstruction can affect the breathing and can cause breathing difficulty, respiratory distress, and even death if you don't identify them just after the birth. And another normal physiological mechanism you have to know is the nasal cycle. We all experience nasal cycle. We feel our one side blocks and stays for some time, and the block disappears. So it alternates from one side to the other. That is normal nasal cycle. That is not a disease, does not need any treatment. It's unconscious alternating partial congestion and decongestion of the nasal cavities, resulting in greater airflow through one nostril with periodic alternation between the nostrils. So it alternates from one side to the other. It's controlled by the autonomic nervous system. And usually it lasts for about 2.5 hours on one side, and then it alternates. The time can change depending on many factors. And what we experience, especially in the night, when you sleep on a side, the side under, let's say you slept on to the right side nose get blocked. There is not disease or not allergy or whatever it is a normal mechanism. If you turn to the other side, it stays for some time and then other side gets blocked. It does not need treatment. And it has a function also. It helps to maintain the mucosal integrity. And when you get airflow, two different types of airflow inside the nose. So one side air goes very quickly, other side little slow. So that increases the range of sense of smell. That's nasal cycle, totally normal physiological thing. So go to the nasal block proper. If you take kids, small babies and children, there are a whole lot of causes, but I just go through only few. Corneal atresia, I think pediatricians, they encounter it frequently than not. As soon as babies are born, always you have to check for this, whether they can breathe through the nose, because most of them are, almost all, are obligatory nasal breathers. Corneal atresia, I'll show you a picture later, can be unilateral or bilateral. And that's one thing. Then different types of rhinitis. Could be a deformed septum. There can be polyps and serious meningoencephalosis. And when they grow a little older, so it's a commonest thing, adenoid, and rarely it can be tumors as well. Yeah, here. I said obligatory nasal breathing. This is corneal atresia. See, this passage is blocked. It's bilateral corneal atresia. If we do not detect it at birth, most likely the baby will die of respiratory distress. Always you have to check for that. If they are having total nasal obstruction on both sides, either at intubate or can be managed with the airway until a definitive surgery is performed. Unless you have a problematic baby. So the management is surgical corneal atresia. The meningoencephalosis. Small kids, they do not get nasal polyp. Remember that. If you see a polyp, this appears like a nasal polyp, but it is not a nasal polyp. It is a meningoencephalosis, which is coming from the roof of the nose. It can come so far down into the nose. It appears like a nasal polyp. And again, the management is surgical. And could be allergic rhinitis, and there are a whole lot of causes of non-allergic rhinitis. They present in similar way like allergic rhinitis. So allergic rhinitis is a huge, vast topic I cannot discuss here. Just to mention a little bit of things about allergy. They usually present with rhinorrhea, nasal congestion, post-nasal drip, and repetitive sneezing. So they have itchiness anywhere in the head and neck area, maybe the palate, nose, ears, eyes, and the skin also. They get frequent sore throat and try to clear the nose and the throat most of the time. And if you examine, you might see the turbinates I showed earlier, a large pale edematous turbinate. That is one of the common signs. If you see this kind of thing, that's called allergic salute. That's the allergy. Management, most of the cases does not need any investigations actually. If you suspect some infection or some problem, you can do a full blood count and can do allergen specific antibody testing. The problem of our country is it's very difficult to avoid most of the common allergens. The commonest allergens in our country is the house dust mite debris. It's very difficult to avoid unless you clean your house and change your bed linen regularly. Get the bedrooms and places ventilated. And the cockroaches, debris of the cockroaches. It's very common. I don't think there's any house in Sri Lanka without cockroaches. And food allergies are rare in our country. Those are very common in other Europe countries, but not in Sri Lanka. In the management, so if you can identify the cause, you can do the avoidance. And medication, common is antihistamine. Topical nasal steroid, usually in the form of nasal spray. There are different kind of nasal sprays. Can be used on even kids about 2 years of age. And leukotriene antagonist. Those are the common treatment modalities. And desensitization like specific immunotherapy, and cleaning the nose with saline. So it clean up the debris and dirt in the nose out that help to maintain the mucosal integrity, and it might clear up the obstruction as well. So, allergy. So I said, now go a little older. Commonest cause is adenoid. There's a natural history in adenoids. It usually start, you don't get adenoid, enlarged adenoid at the time of birth. But when they grow older, at around 6 months of age, start growing. By the age of 2 years, become fairly big, and the symptoms usually start around 2 years, maybe less, maybe late. And it continue to grow for 5, 6 years, and after about 6, 7 years, the size comes down. By the age of 10, usually it disappears, but can persist even into the adult age. Adenoid is situated somewhere in the postnasal space. There is some special thing that opens up somewhere here is the eustachian tube. It opens near the adenoid. So if you do X-ray postnasal space, you see the adenoid and the narrow airway in a child with suspected adenoids, but you don't have to do all the time. So they present with nasal block, especially in the night. Daytime, they are usually okay. And mouth breathing. They keep their mouth open, especially during the sleep. If it is very big, maybe it's during daytime also. And they snow in the night, there may be rhinorrhea. And the problems are, this is the main problem, obstructive sleep apnea. If they are very big, and especially if they are associated with large tonsils, they can have obstructive sleep apnea, which needs surgical treatment. And I said it's a eustachian tube open somewhere here, so it can block the eustachian tube, leading to otitis media with effusion. So, if the baby child after 2 years, around 2, 4, 5, 6, 7 years, have a persistent nasal obstruction, you have to think about adenoids. And you have to exclude obstructive sleep apnea. You have to check whether they have any hearing problem, maybe due to eustachian tube dysfunction. The management, not all need surgery unless they have problems. Just snoring and just mouth breathing is not indication for surgery. Tonsils are the same. Even if you see big tonsil like this, if the child does not have any symptoms, does not need surgery. OSA and persistent or recurrent otitis media, you have to do adenoidectomy. And in some other, most of the minor problems, they have associated allergy as well. So allergic rhinitis can be associated with adenoid. So if you treat the allergic rhinitis, you can get the obstruction controlled to certain extent so that you can avoid surgery and can wait till the child grow older. These are the common, so these common problems in kids. In adults, two kinds of obstruction with some structural abnormalities and no apparent structural deformities. So it can be in the septum, can be deviation, hematoma, abscess, or the lateral wall, so turbinates, hypertrophy, or polyps, or maybe tumor from somewhere. With no apparent structural abnormalities, you get what's called rhinitis. So most commonly it is allergic, but not all rhinitis are allergic. There are a whole lot of non-allergic rhinitis. Always you remember that. So might get some people with symptoms of allergic rhinitis. You give the treatment for usual allergic rhinitis, so they don't respond. That is because it is not allergic rhinitis. So it's a very complicated thing. I'm not going to discuss all those things. They are a bit complicated, even for us, ENT surgeons. So a bit about allergic rhinitis. As I said earlier, I can't go on talking about allergy. Managing a patient with nasal obstruction, if you suspect allergic rhinitis, history is very, very important in the management, because in the history you have to get a lot of details. First thing, how does it affect the patient's day-to-day life? And any provocative factors if possible. Any associated symptoms. And the duration, does it come every day or once in a way or seasonal? When you get exposed to certain things, you get it like that. Unfortunately, most of the allergic rhinitis in Sri Lanka are persistent throughout the year. In Europe and Western countries, you get seasonal allergic rhinitis. But in our country, it is called perennial, persists throughout the year. And do the examination, because there can be associated some other problem. There may be septal deviation, maybe a nasal polyp, maybe some other problems as well that you can't see. So you have to examine the nose well. If you can't get a proper examination, then you have to go for rigid nasal endoscopy. Full blood count might show high eosinophil count, and you can test the allergens by skin prick test or IgE assay. This cannot be done here, but this allergen specific IgE and total IgE can be done in Sri Lanka. Those things help to identify the common allergens, so it will be helpful in avoidance. This is the main part of treatment, avoidance. Again, like earlier, pharmacotherapy, immunotherapy. Pharmacotherapy in adults is usually the nasal steroid. That is the main part of treatment. Use of antihistamine. It's like using Panadol for headache. Until the action lasts, it will be there, but the action wear off with time. If you use the same, let's say whatever it is, fexofenadine or cetirizine or whatever it is, if you use it continuously for a long period of time, the action wear off. The patient will not get any effect after few months or so. The steroid, there are a whole lot of nasal steroid preparations. They are relatively fairly safe, no usual hard side effects. You can use them for a long period of time, but you have to get the correct diagnosis of allergic rhinitis. Then you can start steroid. This topical. And the place of surgery for obstruction in allergic rhinitis. Surgery cannot cure allergic, remember that. If it is plain and simple allergic rhinitis, no place for surgery. But if the patient has severe nasal obstruction due to some reason, then can go ahead with some kind of surgery. So that's why examination is important. There may be septal deformity, associated septal deformity. You can correct it. Maybe the big turbinate, huge turbinate, sometimes you see in allergic rhinitis. You can reduce the size. Or there can be nasal polyps which are associated with allergy. So you can surgically remove the nasal polyps. And as I said, there are a whole lot of non-allergic rhinitis. They also have blocked nose, runny nose, and sneezing, but it is less severe than allergic rhinitis. And again, they can also get smell problem. And if you go deep into the history, you can get certain trigger factors which are not usual allergens. Maybe psychological stress or whatever it is, different things. And in the management, most of this effect of the nasal secretion and edema of the mucosa imbalance due to imbalance between autonomic nervous system. So hyperactive parasympathetic effect. So you can counteract it with anticholinergic. Sometimes steroid is helpful to reduce the inflammation. You can try antihistamine, especially the first generation antihistamines like Piriton, because they have good anticholinergic effect as well. Symptomimetics, again, and nasal, keeping the nasal mucosa wet and intact with normal saline nasal spray and normal saline nasal cleaning, which is very helpful in most of the cases. Normal saline nasal drops are available in pharmacies, and by using normal saline nasal drops, it's very harmless thing. It can reduce most of the symptoms of this condition as well. And this is something special, not very common, but very dangerous, very difficult condition to treat. This rhinitis medicamentosa, that is due to overuse of nasal decongestion. People get addicted to nasal decongestion. When somebody has a nasal obstruction and they go to some doctor, they prescribe kind of nasal decongestion. So they put it, this disappears, no obstruction, patient feels very well. So he continue to use it. So he keep on using that. So the action, the duration of the action, little by little become shorter and shorter and shorter. And in between the doses, he gets huge, severe nasal obstruction due to rebound edema of the mucosa. So it's a rebound phenomena. If you use it for a long period of time, you get it. So avoid prescribing nasal decongestion for a maximum of 1 week. You have to clearly ask the patient not to use it if you are prescribed in nasal decongestion. Very dangerous because it's extremely difficult condition to treat. To get somebody, you have to do the proper assessment and wean off the decongestion and add some nasal steroid, normal saline nasal cleaning, and at the same time good dose to the patient and to the doctor who prescribed it. Good education. So that is rhinitis medicamentosa. You can avoid patient getting medicamentosa by educating the patient not to use it for a long period of time. So why we get obstruction in rhinitis? So this is a normal nasal passage, the endoscopic view. So this is in rhinitis. If you see this is a normal mucosa. And here you see hyperemic edematous mucosa. So one thing is mucosal edema. So the edema of the inflammation, swelling of the mucosa can cause nasal obstruction. When that is there for a long period of time, this turbinate, this inferior turbinate or a concha, they get hypertrophic. So the hypertrophic turbinate size will not go down in between attack or whatever your treatment. But the edema will go down with your treatment, but not the hypertrophy. So remember that. So what to do? If it is only the mucosal edema, you can medically manage it. But if there's hypertrophy, then there's a place for surgery again in allergy. So there is no medical effect. There is no effect of medical management, then you can go for surgical treatment. One is you can diatomize the inferior turbinate. The soft tissue part of the inferior turbinate you can diatomize. So it forms kind of scarring and reduces the size of the turbinate. You can cut part of the turbinate off. And if there are associated polyps, you can remove them. That's a surgical intervention in patient with rhinitis. So, I said earlier, next common problem is the septal deformities. It is a very common problem. About 70 to 80% of population has some kind of septal deviation. So when you see a patient with some kind of nasal obstruction, having a small septal deviation may not be the cause for obstruction. Remember that. There may be, if the deviation is small, there may be some other lesion inside. So always you have to see whether there are some other problems. Sometimes we see patient with septal deviation, they are okay at younger age. When they become about maybe late 20s, 30s, they come with obstruction. So the primary cause is septal deviation. When we tell them, so you have a deviated nasal septum, then they say, so how we got it? It's usually from birth. When you tell them, so this is from birth, they say, doctor, now I am 30 years old age. So if it was there from birth, why didn't I get obstruction before? That can happen. In septal deviation, if you see this is a deviated site, remember this is not a polyp. We get referral also from various people saying that this is a polyp. It's okay, you refer the patient, but don't tell the patient that you have a polyp. That's the other problem. Most of the GP, they send the patient saying that this is a polyp. It's all right. If you tell it to the patient, then it is very, very difficult to take it out of his mind that he doesn't have a nasal polyp. So when there's a deviation, the airflow is less on this side. There is high airflow on the other side. So in theory, patient should not have a nasal obstruction. He should be able to breathe enough because the other side is open. But with time, on this side, the widely open side, the turbinates become hypertrophic. Otherwise, the mucosa become dry and they can get ulcers and crusting and things. So it's a protective mechanism. Turbinate get hypertrophic. So the patient will get the obstruction on the other side as well. So that is the time patient present to you with nasal obstruction. So the primary problem is the septum. Additional problem is the turbinate hypertrophy. This side is wide, the other side is not. And if you see carefully on this side, you see hypertrophic turbinate inside. So they can have associated allergic rhinitis because both are very common problem. This is about 80%. Allergic rhinitis is also very common, so they can coexist. So with a minor nasal septal deformity, they can have allergic rhinitis. So it could be the main cause. In that case, if you treat the allergic rhinitis, patient obstruction will disappear. And there are some people with some psychological problem. They come and say, I have a nasal obstruction. They find some smaller problem inside and they say they can't breathe. So it is very, very important to assess their psychological state also before planning for something surgical in a patient with minor septal deviation. So the proper selection criteria is very, very important. If the patient has symptomatic septal deviation, no treatment will help, then the management is surgery. So we can do it either endoscopically or under direct vision. We do it without making any cut outside. Everything is inside the nose. No external scars. And the next common problem is the nasal polyp. Usually it is associated with nasal allergy. Allergy is nowadays very, very common in our country. When we started ENT, we didn't have so much of allergic rhinitis patient. Nowadays, it's very common. Nearly half the patients in our clinics are allergic rhinitis. So most of them, when it is not under good control, they get nasal. These are endoscopic views. You can't see them like this unless it is so big. Sometimes you can see it outside if it is very, very big. And it can be allergic. This is the, sometimes you can see it outside. So this is the real nasal polyp. This is normal nasal mucosa. So see the color difference. So that's a allergic polyp. Sometimes, see this here. This is bit reddish and with irregular, not smooth tail like this. So this is not a normal, simple nasal polyp. So it is a kind of papilloma, the benign tumor, inverted papilloma that you see in the nose. And sometimes you see various kinds of hemangioma and different malignancies presenting as nasal polyp. So if the patient especially has unilateral nasal obstruction, almost always you have to assess inside. You have to do a nasal endoscopy to exclude some sinister pathology, especially unilateral nasal obstruction. Bilateral equal nasal obstruction is most probably allergic rhinitis, so maybe allergic polyps or something, but unilateral obstruction is serious, could be serious, not is serious, could be serious. And the nasal polyp management wise, those days, long time ago, all the allergic polyps also we used to remove. But nowadays it's not like that. Most of the allergic polyps, once we diagnose it, allergic polyp, we go for medical management first. Main part of the medical management is steroid. Sometimes we use systemic with topical steroid, provided the patient is not a diabetic patient. So, as I said earlier, recent onset nasal obstruction with bleeding, or if it is, and it is unilateral, almost always need proper assessment. Assessment is rigid nasal endoscopy, and if you suspect something, you can go for imaging. Actually, the X-ray sinus nowadays has no place. I tell you, something happened to me in 2000. That's 21 years ago. In UK, I asked for an X-ray sinus OM from a patient. By the evening, I got a mail from the hospital manager, come and meet him. Why? He asked, why did you ask for X-ray sinus OM? If you want to assess the nose, you have to do a CT scan, not the X-ray sinus. So I said, I am from a poor country. We didn't have CT scan to assess each and every patient, so we did X-ray sinus. So that is why I did. So I won't do it again. So he accepted my apology and okay, you go just like that. So it has actually no place. We had to do some time just to exclude various things, and most of the time to satisfy the patient. Most of the patient, unless we do X-ray, they don't believe whatever we say. If you do X-ray and say, okay, this is okay, you have nothing, then they believe. So what to do? Whether we like or not, we have to do something like that. So imaging, CT scan. So I said medical management is steroid, topical, and maybe systemic. If it does not respond to medical management, the simple allergic polyp, you can remove surgically. That's the endoscope. We do endoscopic sinus surgery. With the endoscope, you remove the polyps and clear up the affected sinuses and establish the drainage and the ventilation. Once the drainage and the ventilation is established, the chances of getting recurrent polyps are less. But still, they can get recurrent polyps. So even after the surgery, you have to continue the treatment with topical nasal steroids. And for the cases, other cases, not simple nasal polyp, maybe benign, maybe malignant tumors, you may have to go for what's called medial maxillectomy. You take the medial wall of the maxilla out, maybe total maxillectomy, or if sometimes you get cases going into the brain. So we do combined surgery with the neurosurgeons, craniofacial from above and below. So this is, I got about 3 patients in Kandy, all are young, under 40, have been treated for nasal obstruction by very famous consultants in Kandy. All 3 of them had nasal tumors which were going into the brain. So we had to do craniofacial resections. So persistent nasal obstruction with no obvious reason, don't play around. Get the assessment. If the patient is okay, you can then manage in your whatever it is place. But get the patient assessed. So this is a special kind of polyp. Usually young children, not children, teenage and young adults get what's called antrochoanal polyp. It's not a malignancy, not a tumor. It's a kind of polyp that starts in the maxillary antrum, comes into the nasal passage through the natural maxillary rostrum, and it goes back into the choana. So if the patient has young maybe a girl, maybe a boy, maybe sometimes we have seen in 12, 10, 13 years also. They have a unilateral nasal obstruction. Just look at their throat. Ask them to open the mouth and put the tongue out and see. Sometimes you might see choanal part of the polyp like this. So it is antrochoanal polyp. Management is always surgical, no medical treatment. It's not uncommon, it's a fairly common problem. And this is uncommon but dangerous tumor. It's called juvenile nasopharyngeal angiofibroma. This is exclusively a disease of boys, male, because it is hormone-dependent tumor. Usually teenage and young adults coming with unilateral nasal obstruction and epistaxis. Recurrent epistaxis, unilateral obstruction, always you have to exclude angiofibroma. It is benign tumor, but it can cause lot of problems around because locally it is aggressive, it enlarged, it can erode anything because it's high vascularity, it can erode into the brain. And if it go beyond a certain limit, then we can't operate, considering the place it is. So early detection, you can completely remove the tumor. So this angiofibroma, young boys, unilateral obstruction with epistaxis, always need to be assessed. And sudden onset persistent nasal block, medical emergency, surgical emergency. Sometimes patient has been okay, and suddenly about 2 or 3 days, patient has complete nasal obstruction. May be painful, may not be painful. If it is painful, could be an abscess. It's not septal hematoma. Both you can diagnose very easily. Just lift the tip of the nose and have a look at the nose. You see symmetrical bulging on either side. So if it is inflamed and painful, then it is an abscess. If it is not, it's not painful, it could be a hematoma. The problem is even in hematomas, often you don't have a history of trauma. If it's an abscess, as I said, you get signs of inflammation. These both conditions need urgent attention because this collection of pus or the blood is in between the cartilage and the perichondrium. You all know the cartilage is supplied by the perichondrium of its nutrition. If the perichondrium is away from the cartilage, cartilage undergo necrosis. So if you keep it for a few days, the cartilage necroses and the patient will have a saddle nose deformity, the bridge of the nerve collapse. Then patient has to undergo a kind of rhinoplasty. So it's very difficult after abscess or this thing because elevation of the mucosa is difficult. So if you see them, you can start them on antibiotic and just send them to a place where it can be drained out. And sometimes you get patients, nose is open like what is called Kaiman Dorakada, but patient says, I can't breathe through the nose now. I think all of you must have seen patients like that. We see very common. When you see the nose, you see even the posterior pharyngeal wall through the nose. But they say, no, doctor, my nose is blocked. I can't feel. I can't breathe through the nose. And they can't sleep. They wake up in the night with some obstructive things, but they don't have real obstruction. That's a kind of psychological problem. It's empty nose syndrome. I said something called nasal valve earlier at the beginning. So nasal valve is a functional thing, not anatomical thing. That's a narrowest place on the nerve. When the air goes through the nasal valve, we feel that we are breathing. If we disturb the nasal valve, though the airflow is more than enough through the nose, the person does not feel it, that the air is going in. So they can breathe, but they don't feel it. So they get panic. So that is all. Empty nose syndrome is usually common in psychological disturbed people who have undergone surgery for various things, especially the turbinate surgery, turbinectomy, sometimes for the nasal obstruction. If it is severe, you cut the turbinate off. If you cut a big part of the turbinate off, then the patient might get empty nose syndrome because the valve region is the anterior most part of the inferior turbinate. So we have to be very careful when you are treating patient with nasal obstruction in this way. So psychological assessment is very important here. So if the patient does not have a real nasal obstruction and because of psychological condition, he said he has obstruction, and if we operate and cut the turbinate off, definitely the patient will end up with empty nose syndrome. So that I said, they say they cannot inhale, but the air is going in enough, they cannot inhale and they can't feel it. So if you don't assess them and don't treat them well, sometimes they can commit suicide as well. So you have to be very careful with those people. And you can't just chase them away, also saying that you have adequate space, there can't be any nasal obstruction like that, and you can't chase them away. You have to assess them and do whatever they require. And the management is when the nasal passage is large, as I said earlier, the mucosa become dried out. So it increases the problem. So there's dry mucosa and crusting. So the humidification won't happen. So the patient get dry mouth, dry throat also. So to prevent that, you can do some kind of moisturization. The easiest thing is the normal saline, regular use of normal saline nasal drop and normal saline cleaning. And if there is infection, can apply antibiotic cream. And application of hormonal cream, especially estrogen cream, is helpful. And you know the drug work on erectile tissues. Provided you have given the correct warning, you can use sometimes sildenafil. You have to advise the patient about side effects. And surgically, there are various things. You can implant various things onto the lateral wall or into the septum also. It may be various implant material, and sometimes we can implant fat into the septum, so it make the cavity smaller, so they feel their way, and psychological assessment and help. Okay, in summary, when there's a patient with nasal obstruction, history is the most important part. So in the history, you should be able to identify whether the patient has real nasal obstruction, how long, which side, and does he need any treatment, what kind of treatment, and what could be the possible cause for nasal obstruction. Then you can confirm it by examination and other assessments, and whether patient psychologically stable or he has disturbed psychological problem. And if it's a long-standing nasal obstruction with no major sinister evidence of major sinister pathology, you can try various things, maybe antihistamine, maybe local steroid or whatever it is, but not long-term decongestion. You can try and see according to your diagnosis gained by the history and the examination. If there is poor response or evidence of sinister pathology like unilateral persistent nasal obstruction, increasing nasal obstruction, recent onset obstruction, bleeding. If you see some unusual structure, definitely they have to be referred for further assessment. And again, prolonged use of nasal decongestion is not the treatment for nasal obstruction. Remember that. Okay, I think that's the end of the story. If you have any question, you can ask. Otherwise, yeah. Yeah, rhinolith. You get thing called rhinolith. Rhinolith, you all know, in our body, to form a calculi, you need three things. You need a nidus, you need stasis, and you need some infection. When all those three combine, it forms a calculi. The same thing in the nose. Usually, it's very common for kids to put some kind of small foreign bodies into the nose, and not all the foreign bodies are revealed. And they also don't know, the parent also doesn't feel any problem, so it is left there in the nose. When it is there in the nose, it irritates the nasal mucosa, and a lot of mucus production will be there. Nose get obstructed, infected. So all three things are there. So nidus is there, stasis is there, infection is there. So when those three are there for a long period of time, it forms a calculum. So with time, become bigger and bigger and bigger, and we have seen sometimes huge staghorn like rhinolith, not only in kids, even in adults, 30, 40 years of adult, persists recurrent nasal obstruction and smell. So they go to somebody, given some antibiotic and nasal drop, the smell disappears and they okay, can breathe, and they wait. After about 3-4 months, again get infected, again go to the doctor, get some treatment, get better, like that. So that is rhinolith, can be in children, can be in adults. If you see a rhinolith, management is surgical. You must remove completely. Even if you leave a small piece, it recurs. So you have to completely remove the rhinolith. If it is small, you can remove it on local anesthesia. But in children and large rhinolith, we have to do it under general anesthesia. Because large rhinolith, we have to break into pieces and remove. So they usually present it unilateral, offensive, nasal, maybe discharge, maybe breath. It's unilateral, usually. It's very rare to get bilateral calculus. Okay.
Children, sometimes they come and say that they can't breathe enough unless they periodically hyperventilate voluntarily. It is something like ALS.
No, it is not. It is not nasal obstruction. That is, I think in Sinhala you call it Sankavatamara. It's that attention-seeking behavior most of the time. So you have to get the child and the parent assessed well. Always you have to exclude anything in the nose. You have to examine the nose, but usually it is not in the nose. Because if they, let's say, child is adenoid, sometimes it's completely obstructed, but still they are okay because they breathe through the mouth and they are okay. They get the main obstruction in the night. During the awakened time, they don't feel any problem. So when they are up and about, if they do that, there is nothing to do with the nose. It's common problem. We also get some patients. What you said, that is not due to nasal obstruction. Maybe having some minor thing like allergy or something. You can treat that, but the treatment of the nasal condition will not cure that problem. Need psychological assessment. Not only the child, mainly the parent's problem, not the child problem. Nowadays, everyone wants their kids to take under the 90 to 100 marks in the Year 5 scholarship. That is the main problem. They push their kids always to do study. That is the main problem. If you ask them, they are now in the grade 5 or 4 preparing for scholarship exam. Okay. Right. Okay. Thank you.
Thank you very much, sir, for that wonderful lecture, and it is very illustrative and very explanatory. And moreover, that you know now, Madhuri Dixit was probably in your time maybe the dream star. And thank you very much for that, sir. And today is a special day for us also because another big person in our hospital, and he's supposed to hand over certificate to Dr. Narampanawa, but I cordially invite Dr. Professor Manjula Artigala to talk about him. He's a special person for us.
Yeah, actually, we all know that Dr. Selvaratnam, who is a very senior otolaryngologist attached to the National Hospital Kandy, will be retiring in a few days' time. So we have associated very much in the KSM as well, because he is the director of the EMCK, and we have to have his blessings to conduct our activities as well. So I would like, we have met very long ago, actually, in '96 in Karapitia. I just came across him, and then, of course, in here only after a long time we could associate again. So thank you very much, Dr. Selvaratnam, and I think you have done enormous service to the society in and around Kandy and all over the country as well. But I'm concentrating on behalf of the Kandy Society of Medicine, being the director of the PMCK. We value your support and all the good wishes that you have extended towards the activities of the KSM. And thank you very much. And may I invite Dr. Selvaratnam to give away the certificate of appreciation to Dr. Narampanawa. Thank you.
Thank you, sir. And sir, again, the reminding for the 30th workshop on stroke management, and this is a very good workshop for all the probably the postgraduate trainees. And not only that, we don't charge; it's free of charge, and moreover, you will be paid 1,000 rupees for the participants. So it's only limited for 40 participants, and And also our KSM foundation session will be held on 6th of October. And thank you very much for the physical participants and the virtual participants. Thank you. Sorry, refreshment will be provided in the other room.